Hello everyone, welcome to the series on medical emergencies in dental practice. Before starting with today's topic, I would like to highlight that the most important aspect in the management of a medical emergency is thorough primary assessment of the patient and airway management. And only after this is achieved, the need for any drug administration and possible emergency medical service should be determined. So coming to today's topic, the medical emergency kit. Virtually all dental offices are equipped with an emergency kit. However, in many cases, these consist of commercially prepared kits that are not only expensive but more cosmetic than actually functional. For an emergency kit to be serviceable, the doctor must prepare the kit by themselves and be completely familiar with both the content of the kit and preparation and administration of the drugs present in the kit. Hence, the emergency kit should be designed according to the background and training of the individual doctor. A basic kit for those having undergraduate training and an advanced kit for those with additional training in parenteral sedation or general anesthesia. A basic medical emergency kit should contain drugs that are essential regardless of the level of training. For the ease of understanding, I will be describing these drugs as per the clinical conditions they are used for. These can be placed against a label in the kit for prompt access and usage during an emergency. Starting with epinephrine, it is a sympathomimetic drug that acts on alpha and beta adrenergic receptors. The alpha agonist action shrinks mucosal swelling, while the beta 1 action increases systolic blood pressure and heart rate, and the beta 2 action relaxes bronchial smooth muscles. It also stabilizes mast cells involved in severe allergic reactions. These effects make epinephrine useful during severe bronchospasm, anaphylaxis, and cardiac arrest. 1 ml single dose vials containing 1 mg per ml of epinephrine are more practical for use. A tuberculin syringe with 25 gauge needle attached can be used to withdraw it. Now, since muscle vasculature contains ample amount of beta 2 receptors that dilate vessels and enhance absorption, it is given intramuscularly into the lateral thigh or deltoid muscle, whichever is more accessible, at a concentration of 1:1000. The conventional intramuscular dose for anaphylactoid reactions is 0.3 mg in adults and 0.15 mg in children. Some important points to note here are: sublingual injections cannot be recommended as the dose and rate of absorption have not been studied. Formerly, epinephrine was recommended to be injected subcutaneously. However, absorption and onset were delayed considerably since subcutaneous vessel contains only alpha receptors. The alpha agonist action of epinephrine constricts these vessels and delays its own absorption. The patient should be reassured that a transient increase in heart rate will likely accompany improvement in allergic symptoms. Epinephrine should not be given to patients with ischemic heart disease or severe hypertension, as it can exacerbate these conditions. Now coming to diphenhydramine. It is an antihistaminic that blocks histamine receptors involved in cutaneous reactions. It does not counter effects of additional mediators such as leukotrienes. Diphenhydramine is recommended for management of mild to moderate allergic reactions. 25 or 50 mg tablets or 50 mg per ml single dose vial can be kept in the kit. Diphenhydramine can be administered orally in mild non-life-threatening cases and intramuscularly in moderate allergy, primarily dermatologic reactions. The adult dose is 50 mg, while in children a maximum of 25 mg is recommended. Concentration of 50 mg per ml are not recommended for IV use because of irritation and should be avoided by sublingual injection as well. Alternatively, chlorpheniramine is also recommended by some authors for the management of mild to moderate allergic reactions. The administration is similar to diphenhydramine and the recommended dose is 4 mg for adults and children above 12 years and 2 mg for children below 12 years. Next on the list is albuterol. It is the most selective beta-2 agonist and relaxes bronchial smooth muscles with little or no action on cardiac beta-1 receptors. It is indicated to manage bronchospasm occurring during an asthmatic episode or as the sole manifestation of an allergic reaction. But if the primary assessment reveals both bronchospasm and laryngeal edema, the event is not asthmatic but anaphylactoid and epinephrine is the drug of choice. An albuterol inhaler should be available in the emergency kit along with space chamber for patients having difficulty firing the canister before inhalation and holding the breath for 10 seconds. The recommended dose is 90 microgram per spray, 2 sprays in adults and 1 spray in children. If the initial dose is ineffective, the use of a spacing device is recommended. Now, if the patient becomes hysterical or for other reasons inhaler cannot be used, epinephrine can be injected intramuscularly as described above for allergic reactions. Coming to nitroglycerin, it is a vasodilator that aids by dilating veins and reducing venous return. This decreases strain-induced myocardial oxygen demand and generally relieves discomfort that is attributable to stable forms of angina. It is indicated in acute chest pain in patients with past history of angina and undiagnosed angina with symptoms of myocardial infarction. A small bottle of nitroglycerin tablets is recommended for all emergency kits. It is also available as a spray formulation which is comparatively more expensive. Nitroglycerin can be administered sublingually as a single tablet placed under the tongue and allowed to dissolve and absorb through the mucosa. Now some points about nitroglycerin. The aerosol form does not require special storage and has a longer shelf life than the tablet form, which requires storage in light resistant containers. Also, if a bottle is opened, the tablets expire sooner and should be replaced within 3 months. The tablets should not be chewed or swallowed as it is completely metabolized during first pass metabolism. Nitroglycerin should not be administered to patients taking medicines for erectile dysfunction. It is contraindicated if the systolic blood pressure falls below 90 mmHg, and nitroglycerin can be continued every 5 minutes for a maximum of 3 doses provided systolic blood pressure is at least 90 mmHg and heart rate is within normal limits. Next on the list is aspirin. The antiplatelet action of aspirin prevents platelet aggregation and hence formation of thrombus. It is indicated in patients experiencing chest pain suggestive of ischemia or any other symptoms of an acute myocardial infarction. Non-enteric coated aspirin tablets are recommended for the emergency kit. The tablet is to be chewed for 30 seconds and then swallowed with water. Caution should be taken while administering aspirin to patients with severe bleeding disorders or allergy to aspirin. Coming to atropine, its anticholinergic action counters vagal influences on the heart and allows heart rate to increase. This is generally accompanied by an increase in blood pressure and return of consciousness. Atropine is indicated in case of hypotension accompanied by bradycardia. It is usually recommended to purchase 1 ml single dose vials of atropine. It can be given intramuscularly or sublingually in doses of 0.5 mg or 0.5 ml using a tuberculin syringe. The dose can be repeated every 5 minutes up to a total of 3 mg based on heart rate and blood pressure readings. Atropine is also available in concentration of 0.3 and 0.4 mg per ml, but these concentrations cannot be recommended as dose lower than 0.5 mg may be associated with paradoxical vagotonic effects that result in further slowing of heart rate. Next on the list is ephedrine. This drug not only stimulates endogenous norepinephrine release but also activates alpha receptors on veins to improve venous return and beta 1 receptors to improve cardiac contractility, both of which increases systolic blood pressure. Ephedrine is ideal in case of hypotension accompanied by normal heart rate, as in such cases atropine is ineffective and any further increase in heart rate is unlikely to improve blood pressure. Ephedrine is available in 1 ml single dose vials at a concentration of 50 mg per ml. It can be given intramuscular or sublingually in doses of 25 mg or 0.5 ml. The dose can be repeated once in 5 minutes if necessary based on blood pressure readings. Ephedrine also increases heart rate, and to simplify the emergency kit, atropine can be eliminated and ephedrine can be used for all cases of persistent hypotension regardless of heart rate. Now coming to hypoglycemia. As serum glucose dips below 60 mg per dl, compensatory hormones are released including epinephrine, and this accounts for the early warning signs of tachycardia, shakiness and diphoresis. As the concentration drops further, generally below 50 mg per dl, cognitive and additional CNS functions are impaired. To manage episodes of hypoglycemia, the emergency kit must have sources of glucose such as candies, sugar cubes, fruit juices, and glucagon injection. Provided the patient retain consciousness, he or she can be permitted to take oral glucose such as fruit juice or have candies. Oral formulations of glucose should never be administered if the patient is unconscious because of the risk of aspiration. In such cases, 20 to 30 microgram per kg per dose of glucagon can be given intramuscularly. Next on the list is flumazenil. It is an antagonist for benzodiazepine receptors and counters the effect of any drug that acts as an agonist at these sites. Flumazenil is available as 0.1 mg per ml in 5 and 10 ml multi-dose vials. The conventional dose is 0.2 mg or 2 ml administered intravenously every 1 to 2 minutes up to a maximum of 1 mg. Certain points are to be noted while using flumazenil. It should not be injected in patients who are taking benzodiazepines chronically for anxiety or seizure disorders, as drug withdrawal or seizures may get triggered. The anterograde amnestic effect may not be reversed by flumazenil, and it can provoke panic attacks in patients with a history of panic disorder. Nausea and vomiting may occur following its use, especially when administered rapidly by IV infusion. Another reversal drug to be kept in the basic kit is naloxone. It acts as an opioid receptor antagonist and must be available wherever opioids are used. Naloxone is formulated as 0.4 mg per ml single or multiple dose vials. The conventional dose is 0.4 mg or 1 ml that can be administered by virtually any route including sublingual injections. When administered intravenously, it can be diluted and titrated in 0.1 mg increments to avoid nausea. Now some additional drugs that are usually present in the dental clinic and hence not included in the basic kit. These additional drugs include benzodiazepines, corticosteroids, oxygen, and aromatic ammonia. Injectable benzodiazepine is necessary for the management of prolonged or recurrent seizures and hyperventilation. Lorazepam is the drug of choice for seizures as it can be administered intramuscularly, and the recommended adult dose is 4 mg. Corticosteroid is indicated for the prevention of recurrence of anaphylactic reactions and management of adrenal crisis. Hydrocortisone 100 mg IM is the corticosteroid of choice. Supplemental oxygen is indicated in most emergencies except for hyperventilation. The flow rate should be between 3 to 5 liters per minute depending on the oxygen saturation of the patient. And lastly, aromatic ammonia. It is a general arousal agent with a noxious odor that stimulates the respiratory and vasomotor centers of the medulla. It is indicated in syncope as with proper positioning of the patient and supplemental oxygen, most patient returns to consciousness. It should be cracked or crushed, allowing the release of noxious odor. Now coming to the drugs that an advanced provider such as dental anesthesiologist or oral and maxillofacial surgeon can have in the office. These include 50% dextrose, phenylephrine, epinephrine in several concentrations, labetalol, esmolol, lignocaine, amiodarone, and succinylcholine. A general dental surgeon can also keep these drugs provided he or she is well trained to administer the drugs. Next we will look into the emergency supplies that needs to be available in all dental clinics. These include basic items such as stethoscope, sphygmomanometer, pulse oximeter, thermometer, glucometer, band-aid and sterile gauze, ice packs and Magill forceps. One should also have clear face mask, ambu bag, oxygen cylinder with flow valve and extension oxygen tubing for airway management and administration of oxygen. A high volume suction should be present along with different suction tips such as large diameter tips and tonsillar suction tip, extension tubing and connectors. Disposable plastic syringes and needles should be available for drug administration. And for establishment and maintenance of intravenous access, IV tubing with flow valve, cannula, tourniquet, surgical tape and IV fluids should be available. So that was all about the medical emergency kit. However, I would like to highlight that several points may have been missed out in this video and the drugs and their dose may change with new guidelines. So please refer to the updated and standard guidelines while preparing emergency kit and using emergency drugs. In the upcoming videos, I will discuss about several emergency situations one by one and their management. Till then, if you found the video helpful and informative, then do like, share and subscribe. Also, you can download our app for more details and notes on dental and medical topics.